Hi, Dr. Brian Kaufman, a retired family doctor, CLL patient myself, and co-founder, executive vice president, chief medical officer at the CLL Society here at ASH 2024.
Hi, my name is Meghan Thompson. I'm a CLL doctor at Memorial Sloan Kettering in New York.
Dr. Thompson, Venetoclax, though it can be used continuously, is essentially used in a limited duration therapy. And the label talks about, 1 year in frontline, 2 years when it's relapsed refractory. But there's been issues about maybe there's better ways to do this. Maybe we could look at how the patient responds and if they have any measurable residual disease or MRD. And you've done some research on this area.
Yeah, so I think one of the things that we're seeing in CLL develop is using this test called MRD, or minimal residual disease testing.
I like the word measurable residual disease.
Measurable residual disease.
I hope you're okay with that. Yeah.
That makes sense, because what we're doing is we're measuring the amount of residual CLL cells at a very, very sensitive level. So something that we can't pick up on a usual blood test.
Or a microscopic exam of the blood or the bone marrow, right?
Exactly. We're looking at a very, very deep level.
Give us numbers there.
Yeah, so there's different numbers, and that comes into a lot of the research that's being done. Traditionally we are able to look at what we say 10 to the negative fourth. So that's really one CLL cell in 10 to the fourth cell. So it's a
1
very,
in 10,000, yeah.
very, very deep level. Now we can look at 1 in 100,000.
Yeah.
So looking at 10 to the negative fifth sensitivity. And then there's even more sensitive testing now at the level of 10 to the negative 6. So this is one residual, CLL clonal cell at a very, very sensitive level. And different studies use different markers,
right.
But the point is that we can detect the CLL residual disease at a very sensitive level. And sometimes patients can get to a level where they're undetectable.
So the thought is that you might be able to stop therapy sooner or continue it longer and use MRD to guide your therapy. Am I getting this right? And is this what you were looking at in the trial?
Yeah, so right now MRD testing is still, we call it investigational or used in clinical trials. But we know that patients who are undetectable at the end of 12 cycles, which is the standard in the initial CLL treatment of Venetoclax plus Obinutuzumab, so 12 cycles of Venetoclax-based therapy, have improved outcomes, so improve what we call progression-free survival, or longer time until their CLL progresses. And so we took this idea to say that maybe it's not a one-size-fits-all. Why 12 cycles? Maybe some patients need a little bit less Venetoclax, or can have a little bit less Venetoclax, which has the benefit of maybe developing less resistance, less side effects, reserving the Venetoclax for later on.
Less expense, too.
And less expense. And then there are these patients that are still detectable after a year of Venetoclax. Maybe those patients need a little bit more to try to get them into this undetectable range. So basically we conducted a trial and we did testing, and this is a blood test. It can be tested in the bone marrow, blood, but the decision in this trial was based off of a blood test. And for patients who were undetectable at a very high bar, which was this 10 to the negative 6 sensitivity. If they were undetectable after about 7 cycles, so cycle is 28 days, so a little less than 7 months. And then again, after 9 cycles, at 9 cycles, they completed 9 cycles. So instead of getting 12, they got 9 if they were undetectable. So we used it to guide and tailor the duration of therapy to an individual patient response. Patients then, if they were detectable at that level, went on, they completed and got testing at cycle 12, day 1. If they were undetectable at a 10 to the negative 5th, then they stopped therapy. For those that were detectable, they got an additional year of therapy. So we basically were testing the hypothesis to see for those patients who are early, very deep responders, what are the outcomes if we can shorten the duration of Venetoclax?
So what are the outcomes if you can shorten the duration of the Venetoclax? And do you have any data on the ones where you extended the duration?
Yes. So this was a 100-patient investigator-initiated trial at Memorial Sloan Kettering, as well as University of North Carolina and Stanford Cancer Institute. And looking at our patients, half of patients stopped treatment at the time of this data cutoff for being undetectable after that 9 cycles of therapy.
Wow, that's impressive.
So at that 10 to the negative 6 sensitivity. Yeah. There were another 30 patients who have, at this data cutoff, stopped therapy for being undetectable at a 10 to the negative 5th sensitivity and completed 12 cycles of therapy. And when we look at progression-free survival from the time of stopping therapy, that is, when patients stop, they went into a period where they were off treatment but monitored. The time to progression at this time point is not significantly different between those who stopped after 9 cycles and those who stopped after 12 cycles. This suggests that there might be a potential for really de-escalation of therapy in the sense that maybe there are certain patients who can get less than 1 year of therapy and still have very long remissions off therapy.
Well, we know with chemoimmunotherapy that reaching undetectable MRD is what's important, not if it takes you 4 cycles or 6 cycles, it's how deep you get. And I guess we're trying to find out if that's true with targeted therapies, and your data is suggesting it might be.
Absolutely.
Yeah. Any thoughts about this that you want to share with patients in terms of its implications for therapies down the line?
Yeah, I think that Venetoclax and Obinutuzumab, it's a highly effective regimen. I think what we're going to see, more and more clinical trials that have used an approach of doing the MRD testing to guide duration. There's several other ongoing. This could be, in the future, making its way into the frontline setting. And then there's also data in clinical trials looking at getting to this point of undetectable, measurable residual disease in the relapse setting. So while it's not currently standard, I would say stay tuned because it's being incorporated in many clinical trials and ultimately might have a place in clinical practice.
I'm with you. I think this is part of the future in tailoring the treatment to the patient and how quickly their cancer responds, and we've seen a lot of research on that. Dr. Thompson, thanks so much for the wonderful research you're doing.
Thank you.